I'm Dr. Ed Weisbart. I am a retired family physician in St. Louis, Missouri. I practiced for 20 years family medicine in Chicago, not far from y'all, at Rush Medical School. When I left there, I moved to St. Louis to be chief medical officer at Express Scripts, where I dug deeply into the insurance industry, and I have spent I retired from that in 2010, spent the last 15 years atoning for that. So, so I'm delighted to talk to you. I also serve as the board secretary for Physicians for a National Health Program. And for those of you who are not yet familiar with PNHP, we are a nonprofit, nonpartisan, independent 501(c)(3) of about 26,000, mostly physicians and med students and a few other folks advocating for fundamental change. And given the topic for today, I'll just be direct. We advocate for single payer Medicare for all. And let me be a little bit frank with you. I don't care about single payer Medicare for all. What I care about are my patients that I've seen over the years who had an impossible time getting access to healthcare, who had to make just untenable choices between literally paying their rent and potentially having their grandkids thrust out onto the street or taking their blood pressure medicines. That's the stuff that I care about. However, I believe that the evidence tells me that single payer Medicare for all is simply the most efficient, most effective, most sensible, most prudent way to fix that problem. So I will share with you the information that I've learned over the years that made me come to that conclusion. But I imagine you might come to different conclusions. But we'll show you the information. All the information I'll show you is public domain, peer-reviewed kind of stuff. It'll all have footnotes, that you can link to if you need to. So we'll kind of run through that. We'll explain how healthcare works today in the United States. We'll explain a bit about how it could and should work if we were to reform it. And we'll talk a bit about what that means for physicians, for your future careers. And then lastly, we'll talk a bit about, okay, so how do we do this? What's the strategy? How do we make it happen? And we'll tell you a bit about essentially PNHP's strategy to get us there. So we didn't used to have much of a strategy other than the first two parts. Our strategy was let's just describe the problem and describe the solution. And it's impossible to listen to the problem and the solution without going, of course. And we've learned that that's really not enough. We need to do more. So we have a more robust strategy. So anyway, that's kind of the run of show. Sam, did I get that right? Is that why you invited me to talk today? Yes. Okay, good. I, I would say occasionally somebody says, no, it's not the topic. So, okay. And I believe you can now see my slides, and that's essentially what we're going to talk about. But first, let me introduce you to a member of my family, my sister-in-law, Lori. And if you're worried, don't be worried. I have Lori's permission. If you're HIPAA-centric, I have Lori's permission to tell you this story. Lori lives in Florida, and she has some pretty significant health problems. She has a lot of gastrointestinal problems from her Crohn's disease, as you can imagine. She has possibly related to that some pretty striking scleroderma. I won't tell you more, but a lot of that. She's had some peripheral neuropathy problems, perhaps related to all of that, with some chronic pain as a result. And lastly, of course, she likes to get normal human health care. So she needs all of this stuff, and she didn't have insurance, but she went to buy insurance on the Affordable Care Act marketplace, and I went to help her with that, and it was actually impossible. There was not a single plan on the Affordable Care Act marketplace in her area that included in their network any but one of the physicians that she was trying to see for her care. They each had different ones, but she could only go to one of the four physicians if she were to when she got her care through the ACA marketplace, which means we were literally in the position of trying to decide or anticipate which of her four of her health concerns were going to be the most expensive in the coming year so that she could afford to get. That's just crazy to have to do that. And I'm telling you this because then Lori turned 65 and got onto traditional Medicare. And immediately I had access to all of her physicians that she wanted to see. So you'll see I've called that traditional Medicare. Um, you'll hear other people call that original Medicare. You might be wondering, what's the difference? Traditional Medicare and original Medicare are synonyms, so there is no difference between the two. I just settled on the word traditional. It's the exact same thing. And it refers to the parts of Medicare that were originally created in 1965, which is Part A. Medicare Part A is traditional Medicare's portion that covers inpatient hospital stuff primarily. And then there's also Medicare Part B, as in boy, which covers primarily outpatient type stuff. So when you hear me say traditional Medicare or someone else say original Medicare, we are all referring to Medicare Parts A and B. And we'll come back to that. We are not referring to Medicare Advantage, which is Medicare Part C. And we'll talk about that next week if you come back. So anyway, her access to traditional Medicare meaningfully transformed her life in a way that other countries have figured out already. So here's lots of data condensed onto one little cartoon. And this is 53 years of data. Each one of those lines is a different country. So there's, I think, 30 different high-income countries with a graph of life expectancy at birth versus what the country spends in US dollars per person per year. And a few things leap out from this chart. First, they're kind of similar, all those countries, similar curves. Second, good news, you're going into a good career. Their life expectancies have been generally improving over this time frame, so that's nice. And then the third thing, of course, is how expensive things have been getting over the last several years. You might be asking yourself, or I hope you're asking yourself, well, which one of those lines is the United States? And that would, of course, be a trick question because there we are, not on that chart. And some things leap out. The first thing to notice is that way back in 1970, we were normal. We were in not exactly the middle, but we were in the pack of countries. And now, of course, we are not normal. Now we spend roughly twice as much per person as other countries, and we live several years, maybe 4 years shorter. Our lives are cut 4 years shorter than lives in our peer nations. And that just doesn't seem right. So we should either be spending a whole lot less or we should be living a whole lot longer, but we're not. So what's the difference? How do you account for this? Well, one difference is that all of those countries have some form of national health insurance. There's a bunch of different brands, a bunch of different types, and we're not going to unpack that today. But every one of those countries guarantees cradle to grave, free, if not low cost, access to the whole menu of physicians and hospitals in their country. We don't do that, as you know. We don't do that. But we have not been sitting idly by. We've tried a whole bunch of things over the years, starting with the HMO Act, which created the managed care industry in 1973, I think that was, ostensibly to lower the cost of healthcare. It's pretty hard to see that the HMO Act lowered the cost of healthcare. In fact, it looks like, if anything, the opposite. And then a whole range of other things that we've been trying over the last several years, none of which has actually impacted this chart in the way you might want it to. And we're not going to unpack each one of those. Just I'm pointing out that we've done a lot of things. We've tried a lot of different things, and they don't seem to be bending the curve in the way we want. So how does it work in the United States today? So here's all of us on the left, and then there's all of the healthcare services on the right. And of course, in between people and healthcare services is money. And how do we manage the money? That's the key. That's one of the big differences between us and all those other countries I showed you. Well, we have what are called payers. So the United States federal government is one of the payers. They pay our taxes go to the U.S. government, and then they pay for almost all of Medicare. They pay for half of Medicaid. They pay for the health care for the military. They pay for health care for all federal employees. They give tax breaks to employers. There's a whole bunch of ways that the United States pays for healthcare, and then states. And I'm sorry, but that's the state of Missouri and the state of Missouri, both. That's the state of Missouri. States also pay, of course, for the other half of Medicaid. They pay for state employees and a range of other things that states pay for healthcare. And then there's cities. They pay for certain employees and certain other healthcare programs and extra credit if you knew that that's the city of St. Louis, where I live. Then there's schools. That's the University of Missouri. They pay for student health and some other related things. Then there's businesses and there's insurance companies and yada, yada, yada. This could be a much more dense cartoon, but there's a whole bunch of payers. These are called payers. And we are a multi-payer country. That's how our insurance is set up. So we pay one way or another to each one of these for access to healthcare, and then they each pay physicians and hospitals and pharmacies and all that happy stuff. So right off the top, you can see that this is a pretty complicated cartoon. And if you're a fan of quality, you know that complexity is the enemy of quality, but there's this complex pattern. There's gaps in between all of this, and it's a little bit more complicated, of course, because you can't just go to any doctor or hospital or whatever. Most of those payers will say you can go to this doctor, but not that doctor, or this hospital, but not that hospital. So it's, really complicated. And it's not just bewildering. That complexity is actually pretty expensive. So if you look at what we spend per person per year, a little different data source compared to the chart I showed you earlier. But if you look at what we spend per person per year, you can see that we indeed are spending roughly twice as much as most other countries spend. But I'm showing you this chart because there's an important difference. Almost all of the dollars in blue are public funding for those countries, whereas in the United States, the green bar is the public funding for healthcare. So that's, as I said, our taxes that go to the federal government for Medicare, for Medicaid to pay for the public employee healthcare and a variety of programs. And notice that that number is on par or in some cases below what other countries spend. And then on top of that, per person per year, on top of that, there's another $4,600 per person per year that we spend through insurance premiums and out-of-pocket dollars and all this other stuff. So we've got enough money to pay for a universal healthcare system. We've got more than enough. We're spending plenty just in our public funds. The other thing I want to point out about this is that this chart shows you roughly two-thirds of the money that we spend coming out of public dollars, and you'll often see a ratio that's closer to a half or even a little bit less. And the difference there is that I'm including in this chart the money that we don't collect in taxes because we give employers a tax break for paying for the premium, and we're including the public employee funding, which isn't. Most of the other charts that look at this only look at Medicare and Medicaid and stuff like that. So if you really look at what we're spending publicly, I think this is a fair way to look at it. At any rate, we have more than enough public funding to pay for a universal system, and yet we're the only country that doesn't do that. And part of that is because of how expensive it is to run an insurance company. So if you look at insurance company overhead and profits from their SEC filings, pretty good source, you'll see that I usually just say 15%, 13 to 15% is the overhead that we pay to the insurance companies. Is that a lot? Yeah, it's a lot. Traditional Medicare, which you now know what that means, traditional Medicare operates with a 2% overhead. Is that magic? I mean, how do they do that? Well, there's a lot of stuff that traditional Medicare doesn't have to do that the insurance companies do. The insurance companies advertise all over the TVs. The insurance companies have legions of staff that do sales and account management that work the employer base. They have legions of staff that say, no, you can't have that health care. They have legions of staff to do the appeals and the denials. And there's a whole range of things that the insurance companies do, frankly, in search of their own profits, that traditional Medicare just simply doesn't do. So traditional Medicare has a fraction of the employees that per unit base than the insurance companies. So traditional Medicare, way more efficient. When we get to Medicare Advantage next week, which is the commercial for-profit version of Medicare, you'll see that the overhead starts to climb back up. But for traditional Medicare, it's literally 2% overhead. And perhaps it should be a little bit higher. There are perhaps some things that we would want traditional Medicare to be funded to be able to do that it can't do today. So maybe it should be 3%. I don't know. But 2% is the number that it's at. Turns out the insurance company reported overhead is not the biggest part of the waste that we spend on them. So this is, let's say, 13 to 15%. In total, best estimates are it's more like 33 to 35% that goes to the overhead of running an insurance industry. And that's because they hide the other half of what the overhead is. So, for example, a typical physician, according to Milliman a few years ago, a typical physician has about $100,000 of staff just managing the interface with the insurance industry. So the fee schedule has to be jacked up enough to pay us to hire those people. But when you look at the overhead that we pay out of our revenue in practice, that doesn't get counted anywhere as the overhead of the insurance industry, and yet, of course, it is. And then hospitals equally have hidden overhead. So here's an interesting little comparison of Duke and the University of Toronto. University of Toronto is actually a little bit bigger hospital system compared to Duke, but in ballpark same size. So for about, let's call it 1,000 beds, Duke publicly reported that they have 1,600 billing clerks for their 1,000 beds. That's actually high. If you add up the number of employees in the country who work for billing in hospitals, it's about 900,000. And if you add up the number of hospital beds we have in the United States, it's about 900,000. So across the country, we have roughly one hospital-based billing clerk for every hospital bed. We don't have one doctor for every hospital bed. We don't have one nurse, but we do have one billing clerk. So hooray for us. So Duke is actually a little bit, actually it's 50% above the norm for the United States. So Canada, University of Toronto, an even bigger hospital. So what do they got? Like 1,500 employees? No way. Oh my gosh. Seven. You can count them on two hands, literally two hands, seven. And my understanding is that four of those seven are to take care of Americans who came across the border for some reason and broke their hip or something. So so the billing clerks in the United States, they're not evil. I've known a lot of folks in that industry, and they're really good people trying their best to help patients work through this complicated system that we've built up. But it's hard to see at the end of the day the value that diversion of labor force is adding to health outcomes when a country that I just showed you lives longer than we do, can get by with a tiny fraction of what we spend staff on, and that's all hidden into the overhead and doesn't ever get counted when you hear reports of the overhead. So we have to include, I think, what we physicians spend on overhead and what hospitals spend on overhead interfacing with the insurance companies. But none of you care about that. None of you care about any of that, probably. Like me, you probably care more about this. We care more about sort of health outcomes, and that's one of the places where Medicare is really great, really excels at. So here's one of my wonkier charts, and this came from what was at the time called the Institute of Medicine, and this looks at mortality rates by age in different countries. So stratified by age. So it's ranking of mortality rates. So if you're number one, you have the best life expectancy basically. And if you're at the bottom, you have the lowest life expectancy by age. So you can see children are all the way to the left, and I'm getting further and further to the right on this chart every year. So as you are too. So we can see, that's how this works. So obviously you want to be at the top of this chart, not the bottom of this chart, but oh dear. There's the United States spending twice as much as these other countries, basically, per person, and yet we have arguably the worst mortality rate or life expectancy compared to 17 peer nations, and they're on the chart. You can see that it's Australia, Austria, Canada, Denmark, they're all down there. So there we are, worst in the world, despite spending in the wealthy part of the world, despite spending so much, until the magic happens and we turn 65 And then country by country and year by year, we climb to literally the best in the world. We climb to literally the best in the world. So again, hooray, you're in the right place going to med school here in the United States of America. We have many of the world's best doctors and hospitals and nurses and pharmacists. We simply must, or we could not accomplish this. The problem, I submit, is we just don't let everybody in. We just don't let everybody use our healthcare system. We put in all these crazy barriers. So let's stop doing that. Let's get rid of this mess and get rid of all of that stuff and switch to one single payer instead of the multi-payer model, one single payer. And I would argue we are still in 2025 at a period where Medicare is still the core of a really effective healthcare system, and we should simply build on that and let everybody have access to it. So improve Medicare in some important ways that I'll mention, and then expand it to every American. So these are all different ways of describing the same thing. Some people will call it single payer because it would be just one payer. Some people will call it Medicare for all because we would perhaps pick Medicare as the single payer, so you can call it Medicare for all. Be more granular, you could say a national improved Medicare for all. So these are different ways of describing the same thing, but or similar things. But that's kind of what I think is a good way forward. So improved Medicare, not Medicare as we have it today. And what does that mean? First of all, there's a bunch of things that Medicare simply doesn't cover because in 1965 they weren't things that they built into the program. So, it needs to cover pharmacy. Traditional Medicare doesn't have a pharmacy benefit for outpatients. It doesn't cover hearing aids, doesn't cover eyeglasses, it doesn't cover long-term care, it doesn't cover abortions, doesn't cover a number of things that if you were to make this available to everybody in the country, you would have to expand the benefit design. So there's a much longer list of things actually, but all medically necessary care would need to be covered. And then get rid of these absurd financial barriers to care. So there should be no copays, there should be no deductibles, there should be no premiums. A $10,000 premium for somebody making $300,000 a year is quite different than a $10,000 premium for somebody making $40,000 a year. So that's called a regressive tax when you have to pay that much more of your income to get into it. So get rid of all that stuff. And if you made it cover, if you did all those things, then you wouldn't have to buy Medigap. You wouldn't have to supplement the insurance product. So because of the copays and deductibles, which are pretty significant in Medicare, most people purchase Medigap if they're in traditional Medicare. And we're going to talk quite a bit more about that next week. But that all disappears. No need for Medigap, no need for Medicare supplemental insurance. None of that is necessary if you do the first two things, cover all care and eliminate the copays and deductibles. So how do you fund it? Well, you would fund it the same way that we fund anything else that we think is a public good. Most places fund their fire department and roads and schools and water through a progressive income tax system. And I would argue that healthcare is just as important a public good as sewage collection and clean water and the other things that most of us would agree are public goods that everybody should have access to. So equitably funded through the same equitable progressive tax model. So that's the first thing. And then related to that, of course, is that even Medicare's method of paying physicians has gotten really complicated. So we don't think that's necessary. And we think there's a number of ways we could greatly simplify the way physicians are reimbursed under Medicare for all. There's a bill in the House and a bill in the Senate that would create this improved form of Medicare for everybody in the country. And it specifically does these things, including simplifying the payment model for physicians. So there's more, but that's most of what we mean by improved Medicare. And then stop leaving people out. Cover everybody. Cover everybody. Cover kids. I don't know if you know, but the majority of children today are covered by CHIP, Children's Health Insurance Program, which is a form of Medicaid. And that CHIP bill has to get renewed every 5 years, I think it is. And if they choose not to renew it, then the majority of children in our country would suddenly be uninsured. That's just craziness. Children should be in the same healthcare program. Seniors, of course, should be in it. And the list of things I just showed you would mean seniors wouldn't just still have Medicare, they would have improved Medicare. So they would get a win out of this too. It should not be linked to your employment, it should not be linked to your immigration status. I mean, I don't want somebody sitting next to me on the bus who can't afford to get their tuberculosis treated. If you're living in the country, I don't want you unable to work because your diabetes has made you disabled. I mean, of course, if that happens, then you should still be able to live here and you have access. But if you're here, we want you to be as healthy as we want the system to help you be healthy for a whole range of reasons. We want that. So, does that mean that you can hop across the border and immediately spend the next 6 months in Mayo Clinic and have that be tax funded? No, it doesn't mean that. The bills that are in the House and in the Senate explicitly put language around how immigration status and residency and all that stuff gets defined. So there's stuff about that, but in general, not require citizenship for access to healthcare. Um, Cradle to grave, of course, kind of goes without saying based on what I said, but it's worth emphasizing again. And again, it goes almost without saying, but this notion of pre-existing conditions. No, I'm sorry, you're too sick to have access to healthcare. That's just craziness. That wouldn't be a phenomenon under this. It is in parts of Medicare and Medicare today that we will get to next week, Medicare Advantage and stuff, but it's not today. And then last, of course, it would mean that patients get to pick whichever doctor and hospital they want to go to. Today, something like 99% of physicians accept Medicare. I think something like 90% of physicians accept new Medicare patients. I don't know exactly the number, but they don't. Most physicians don't accept new patients or some physicians don't accept any new patients. So, but the insurance product wouldn't be restricting your choice. You would have free access of any doctor or hospital anywhere in the country. And this is meaningful if you live in Wisconsin, but want to spend 3 months out of the year in Arizona for reasons I wouldn't understand. But if you wanted to do that, and you needed to get access to somebody to help you with your diabetes when you were in Arizona, you would be able to see a primary care physician in both Wisconsin and Arizona. I defy you to find a program other than Medicare that lets you do that. So this means you could go really wherever you want. Um, so what about hospitals? I mean, we love our hospitals. They're so pretty, aren't they? We don't want to hurt them. Anybody recognize these hospitals? They're Canadian. It turns out, even in that crazy country, Canada, that has a single payer system that we're kind of structuring our system on, they have hospitals too. So it turns out they have really good hospitals. How do they do that under single payer? Because we wouldn't want to hurt our hospitals. So they do it by a system that's called global operating budgets. Rather than paying for every little service, they put hospitals on global operating budgets, which is part of the bills in the House and Senate, is what we propose here too. So let's see how this works. Hospital financing today, hospitals are paid a fee for a case that they take care of or for a service that they deliver. So hospitals today are chasing procedures, and those procedures, some of them are paid just a little and some are paid a lot. So psychiatry, mental health stuff tends not to be well reimbursed. Maternity care, and that stuff doesn't tend to be very well reimbursed. So we see maternity units closing around the country. We see psychiatric hospitals not really flourishing, whereas cardiovascular hospitals and oncology hospitals and orthopedic hospitals, those are actually sprouting up. So hospitals invest where the money goes. And I have nothing against those institutions. I mean, many of them are really terrific, but our finance model alters what our delivery system looks like because they just do what they need to do. Hospitals today spend a whole lot of time telling you how to code your visits and how to optimize your what you think you've done so that they can get the maximum of reimbursement. And that's all pretty distracting to patient care. And you're mostly M1s and M2s. You haven't run into that too much, but you will, trust me. And then lastly, one of the big problems with paying for the services like this is that, when there's a real crisis in the country, like a pandemic, hospitals stopped doing elective procedures. Well, those are the expensive ones. That's where they get their money, right? They stopped doing hip replacements if they didn't absolutely, they stopped doing the stuff that makes their money. So hospitals had fiscal emergencies during the pandemic uh, when we most needed hospitals. Well, that's crazy. That's crazy. So they laid off nurses. Hospitals during the pandemic had nurses that they didn't let come to work, whereas they should have been deploying them into community health. This is such a misalignment of health outcomes with healthcare finance. In contrast, under Medicare for All, there's a predictable, negotiated annual budget for each hospital, for each individual hospital. So the system wouldn't negotiate on a block of hospitals where each hospital have its own budget. They could still be organized in clusters, but the budget for each one would be hospital specific. Way more efficient, far less overhead. As you saw, my 1,600 for employees for Duke versus seven for University of Toronto, far more efficient way to run a billing program. It would mean you'd no longer be on the hunt for the procedures that are the most lucrative, and instead you could align what you need to do with the public health. You could, today, if you think about it, a hospital that invests strongly in reducing cardiovascular morbidity and mortality in their community, which takes, 10, 20 years to do that. But a hospital that invested in a campaign to reduce cardiovascular morbidity and mortality 10, 20 years later would have reduced the demand for their most lucrative procedures. So why would they do that? And the answer is they wouldn't do that, or they do it some, but this model we have today perversely corrodes public health imperatives for some of our biggest healthcare delivery systems. So we need to fix that. That to me is one of the more compelling arguments, but not to everybody. So can we pay for it? I kind of showed you at a high level. Yes, we can, and at an even higher level to show you literally hundreds of top tier economists don't say we can afford it. They say we can't afford not to do this. We have to do this like immediately. And perhaps the most trustworthy, neutral, source, the Congressional Budget Office. Everybody hates the Congressional Budget Office. It's nonpartisan. It's non-biased. So Democrats and Republicans tend to hate what they come out with because it just says the facts. It doesn't in any way influence things. They're very well respected, or at least they have historically been. Landscapes are changing, but they are a very respected source. And they looked at it and they said, hey, here's six ways you could define that you could create a single payer universal healthcare system. There's six different models that they speculated on, two of which were built really closely on the statutes, the legislation that we're proposing. They said under all these models, eliminate all or nearly all of the copays and deductibles. None of the models they looked at and none of the other mainstream economic analyses that say we can afford this said in any way to reduce revenues to physicians. In fact, most of them said increase the revenues. And indeed, the CBO reports increased provider revenues and still said you can do all this, Congressional Budget Office, you can do all this and reduce what the country spends on healthcare. So don't let anybody tell you we can't afford. Would this mean more taxes? Well, of course, we're talking about a publicly funded program, but it would mean no more premiums. It would mean no more copays, no more deductibles. So instead of paying a premium, a big premium, you would instead pay a smaller increase in your taxes. So your total spend as a citizen and the total spend as a country would be less, even though, of course, it would be more tax related and less commercial industry related. But the total spend for the country and the total spend per person would be reduced. Why do physicians care? Why should you care? There's a whole host of reasons. I'm just going to focus on a couple, three of them. Probably the most compelling one to me is this. Physicians care about this because we just can't stand practicing the way we have to practice today. We have this crisis where we do all the hard work, we do the heavy lifting, right? We go to school, go to residency, learn all these stuff, acquire all these skills. Then we go into this small room with a complete stranger, and in a minute or two, build a relationship where we want to listen back and forth and they trust us and we figure out what's wrong with them. We kind of figure out a range of solutions and we negotiate with them. Here's how we want to approach this. Here's how you think we figure that we do that hard stuff only to then have the patient come back later and say, well, I can't afford that. The insurance company won't pay for that, or to even ask you, how much is that going to cost me, doc? And we've got, somebody who came in to the office with a TIA, right? A warning sign of a stroke, a transient ischemic episode, and she was, numb and paralyzed, on half of her body for a few hours. She came into the office. She had a bruise on the contralateral side, and no residual neurological defects. But I wanted to get an image, a vascular imaging of her, and she was 64 and a half years old. And she said, well, what's that going to cost? She didn't have any insurance. And I said, a lot, thousands, I don't know. And she says, well, doc, if I want to keep living in my house, that's not going to happen. So I'm going to pray and wait until I turn 65 and have Medicare, and then we'll go get it. Terrific. So that's what happened. It worked. Didn't have a stroke. She went and got imaging, found the blockage. When she turned 65, found the blockage, had an endarterectomy, and she didn't have a stroke. So, hooray! But for 6 months, that's so we have that patient, and then you go into the next exam room, and there's another patient. Then you go into the exam room, and there's somebody else who tells you this, and this accumulates to us. This harm, this moral injury accumulates, and knowing that it's just because of a profit-oriented system, and then we're forced to contribute to it. We often have to be the agent delivering this dreadful news that here's this expensive thing that would save your life, but here's this not so expensive thing that might save your life. We have to be the agent and it's killing us, man. I mean, it's terrible to go through that over and over and over again. And PNHP actually is nearly done with a new report about this moral injury, and it's probably going to be released in December. So stay tuned for that. So that's one of the main reasons that motivates me. I can't stand being in that situation. But there's other reasons that we should want this. I don't know what medical record y'all use up there in the North Country. But Epic is one of the most common electronic medical records. And one of the fun things about an EMR is you can extract information that would otherwise be really hard. So here's researchers that extracted the number of characters, number of characters in an ambulatory progress note in Epic. Number of characters, and counted them up, and then looked at institutions. And it turns out that around the world of institutions using Epic, the average is about 1,000. The typical ambulatory care progress note in Epic around the world has about 1,000 characters. And then with no overlap, in the United States, the typical ambulatory care progress note is 4,000 characters. 4,000. Why is that? Is it because care here is so much better? Well, remember, those countries all live longer than we do, so that can't be it. No, it's because you have to document to get reimbursed. Most of the reimbursement models require extensive documentation. If you didn't document, you didn't do it, you're not going to get paid. So much more documentation for reimbursement, and of course, much more documentation to avoid being sued for the same reason. If you don't document it, you didn't do it, and then they can come after you and sue you, which you don't want to have happen. So why do people sue? They sue because something bad happened, be it our fault or not our fault. But then maybe they can't keep working. And then maybe they lose their insurance. And then they need somebody to help them pay for the future cost of their health care. Whether it was your fault or not, they need somebody to help pay for that. The most common reason to sue is to pay for the future cost of health care. And the biggest part of the judgment against a physician when we lose is to pay for the future cost of healthcare. So under these other countries, they don't need to sue for that. And if they do sue and prevail, it's a much smaller judgment against them. So it's just, malpractice isn't really a thing that gets talked about in these other countries. And so the premiums are a fraction of that. So the two biggest drivers of these crazy long documentation data don't exist elsewhere in the world, and so their charts are shorter. So when you're in clinic or in the hospital and you're making your progress note and you feel like 3/4 of what you're writing isn't really adding any clinical value, That's because, let's see, what's the math? Three-fourths of what you're doing isn't adding any clinical value. It's just medical legal risk avoidance and it's revenue optimization. It's not clinical. And in fact, it interferes clinically because it makes our notes like this nightmare to read through and figure out what people are actually thinking. It's so that's another thing that single payer wouldn't immediately fix. I mean, we have a culture now of these notes, so it wouldn't immediately all shift, but yeah, it would take away the drivers, and then it would improve that. So yeah, in Canada, they don't understand what we're talking about when we bring up malpractice. And that's if you look at just the number of lawsuits. In the United States, 1 in 3 physicians will have been sued before they turn 55. And that means that if you add it up across a lifetime, there are 68 liability claims for every 100 physician lifetimes. 68 for every 100 physician lifetimes. Canada, though, the number is 732. Of course, that's total claims against 105,000 physicians. So they don't sue people in Canada for the reasons that I was just saying. Now, we are maybe a more litigious society, so it's not just this, but yeah, this doesn't really happen in Canada. So hooray, they don't have to worry about this stuff. And I didn't pull the Wisconsin data. I think Wisconsin data on malpractice premiums is actually better than Missouri, where I live, but it's still nowhere near as good as the Canadian data. So, and this data is publicly available. You can find it at my links. And income, as I said, the models for income don't show us being hurt. Here's in US dollars, 2024 revenue for Canadian physicians versus United States physicians. And is it really apples to apples? Well, it's converted, to US dollars, but, Canadians pay higher taxes, but they also get more stuff. They get healthcare for their taxes. So it's hard to know if this is like really apples to apples. But in general, they're not all driving 35-year-old Yugos. The Canadian, in most countries, actually, physicians and as I said, none of the models about single payer impose in any way a reduction in what physicians would get paid. And in fact, since you would have much less office expense and much less malpractice premium, in fact, income would be protected, not hurt. So you don't need to be worried about that. Last part of this chapter before we get to strategy is you need to get this book. You need to get this book. It's a hard name to remember. How do you remember this? Medicare for All, a citizen's guide by two physicians, Abdul El Said and Micah Johnson. So there's a dozen or so books on the market today about Medicare for All. I have read many, maybe all, I don't know, of them. This is, in my humble opinion, this is my personal opinion, hands down and away, this is the one to read. It's very readable. It's got wonky level information, but it's not at all wonky. It's like a narrative almost. It's got a chapter on every one of the major topics. It's heavily referenced, so you can go back and get the primary data if you're curious on that. It's the book to get. I would recommend. So that's the what, and then there's of course the how. So we used to just simply say, PNHP used to simply say, if we build it, of course, if we describe it, that's all we need to do. So then after Bernie Sanders' campaign, actually, we realized that that was no longer enough. Describing single payer is not really enough. And so we've got what we now call our triple aim. We have 3 parts of our strategy. The first is, of course, our true North Star. Single payer is still where, everything is laser focused on getting us to that. But we have 2 other strategic legs to this. Ending the profiteering and improving traditional Medicare. So improving traditional Medicare is pretty straightforward. We want to do the things that would make Medicare a better program, which we need to do anyway. Some of the improvements that I mentioned, earlier on, we may as well start improving traditional Medicare, make it a better program now. So limit out-of-pocket expenses so you don't need Medigap. Expand the benefits, expand, hearing, vision, dentistry, and all that other stuff. And then lastly, include things like long-term care, and we can talk more about that. But there's a whole range of things. And our second leg, which is improving traditional Medicare, and there are legislative initiatives to add things like hearing, vision, and dentistry into Medicare. So there's that second leg. And then the third leg, where we spend a lot of time focused on, is the profiteering, because we believe that the profiteers are frankly destroying our healthcare system in the name of their own profits and not in the name of health improvements. So ending the profiteering is an important part of our campaign. And for the last, I'd say, 3 years, we've done a lot of work trying to expose Medicare Advantage and how that's actually really damaging the Medicare program. And as I said, we're going to talk about that in detail next week. The last 6 months or so, we've also been focusing on Medicaid. Turns out Medicaid has been taken over by the profiteers even more than Medicare has. So we've got a whole range of things we could talk about Medicaid deprivatization as well. So that's when we talk about ending profiteering, that's stuff that's what we mean. Although there are a myriad other ways that the profiteers have invaded space. They own medical groups. The United Healthcare employs 90,000 physicians. Like 10% of the doctors in the country work or are directly contracted for United Healthcare. We all have to make our own decisions, but there's a bunch of other ways that profiteering is engaged. We don't have the bandwidth to approach all of those. We focus on these two at this point. So it turns out that we think these are the roads to get there, but it's not that simple, that there's a barrier between here and there, or we'd already have gotten there. So our strategy is more, how do we get past that barrier? And to get past the barrier, we need more organizational power. PNHP does. And so that means we need more members. So we have strategies to try to get more members. It means that we need to raise money, and virtually all of our money is from membership dues, and we have now had two grants as well, but they don't come really with meaningful restrictions, and we don't take any money from pharma or the insurance companies. But we've had, healthcare advocacy type groups will give us a couple of grants that funded our last two reports. So hooray for that. So fundraising and grants, we have a whole suite of campaigns for that to build our power. We need to build even stronger relationships with legislators, and we're doing a lot of work on that front. And then lastly, we need to not be the lone voice out there like we once seemed to think that we were. Turns out that there's a number of other organizations out there across the political spectrum, well, not across the whole political spectrum, but out there that are also pursuing this goal. And so we've been more thoughtful lately about what's our role in this advocacy community. And PNHP, a few of us literally meet every 2 to 4 weeks with, I don't know, maybe 24 non-PNHP but friendly organizations like Public Citizen and Social Security Works. And I shouldn't mention any because there's many. So a much stronger advocacy community than we thought a few years ago, and that's all in the name of building power. So our strategy has allowed us to do things that we've never been able to do before. Can you tell I'm a Star Trek fan? So boldly go where no one has gone before. So first, fighting profiteering. We didn't used to talk about that as a specific goal, but the idea here is that there are a lot of groups who really aren't single payer, maybe some of you who really aren't single payer advocates, maybe I didn't persuade you, who really don't even agree with us, who actually disagree with us about that. But despite whatever they think about single payer, they really hate the fact that these profiteers are just draining public funds. They're just taking taxpayer dollars into their investment community and not into what taxpayers think they're paying for, which is healthcare. They hate that. So we have a number of allies who disagree with us about single payer, but who completely agree with us about the profiteering problem. And you know what? That's just dandy. So we can work together with them on fighting the profiteering. And then when we get to forks in the road, that's fine. Then we just kind of go our different pathways. But I am here to tell you that some of them who would have never talked to us 5 years ago, because our policy used to be, people would ask us about a healthcare policy, and we would say, well, that's not single payer. We don't like it, and walk away. End of discussion. And then they would stop asking us. We no longer give that answer. We look at our strategy, the triple aim. Does it fit with that? And if it does, let's talk. Let's figure out how to collaborate on this. So by doing that, by having thoughtful, evidence-based, concerned, patient-centric discussions, some of the folks who, said, no, single payer, terrible, communist, they don't say that anymore. They're moving closer and closer to collaborating with us. So that's the biggest group of our allies now, are the people who agree with us on that. A subset of that are the people or the organizations who think that that wasted money should be redeployed from the profiteers into the improvements in traditional Medicare that we've alluded to. So there's a lot more. So there's a lot of organizations out there that agree with us out that. Not everybody who wants to fight profiteering agrees that that's where the money should go. Some say the profiteering money should go into just reducing taxes, reducing the national debt, whatever. There's other things that reasonable people could think that money should be redeployed at. But a large subset of those folks agree with us that that money really should go where it was intended, should go into improving into healthcare. So, but not everybody who wants to improve traditional Medicare wants to do it for the same reason we do, which is because it's the right thing to do and because we see it as a pathway towards single payer Medicare for all. Not everybody agrees about that. And again, that's just dandy. And so a lot of groups we work with on this don't agree with us on that, and yet they seem to be getting closer to agreeing with us more and more on that. And then, of course, the true north in our mind is single payer. But it's clearly true that that's our mission, that's our goal. We think that would create the governance that would get us further ahead. But, clearly that's necessary, but not sufficient. There's a whole bunch of other things we would need to do, most of which would be easier to do under a single payer model. So that's our priority is getting to this. And then there's more work to be done. The last thing I want to tell you about is, the next to the last thing, is we've got a bunch of reports on our website. If you go to our website, the top menu bar has proposals and reports. And so there's one from 2 years ago now that looks at Medicare Advantage. Pretty good overview. You might want to read that before next week. Looks at how much they're overpaid and how we calculate that. And then a year after that, we came out with a report looking at frankly, how much harm Medicare Advantage is doing. And if you have time, you should look at that one. And then today, today, October 15th, 2025, we released this new report after 6 months of working on it that looks at how Medicare Advantage actually perpetuates inequities in healthcare, and in some cases actually makes it worse. So we'll talk about this stuff next week. Two other reports. Last month, we released this report about Medicaid and about how much money states could save if they pulled the insurance companies out of Medicaid in their state. And spoiler alert, most states would save a few $100 million a year and improve health outcomes. So save a few $100 million a year and improve health outcomes if they kicked the insurance companies out of their Medicaid program. And then lastly, as I mentioned a couple of months or so, we're going to be releasing this new report about how financialization of the healthcare system writ large is really damaging, all of us in the healthcare system. Very last thing, in case you don't know, and in case you're looking for something to do the weekend of November 1st through 3rd, come to DC, man. Find a way. Get, planes, trains, and automobiles. Get to DC for our annual meeting. It's going to be a killer meeting. Don't use the word killer in healthcare. It's going to be a great meeting in DC. There's a QR code so you can find more information. It's, of course, on our website. So on Saturday, in the morning from 9 to 2, I think, Eastern time, it's going to be a student summit with kind of the basics of single payer stuff in more detail and how students can engage in strategies for students. So in the morning, there'll be a student-centric focus, and in the afternoon, it'll be a whole range of new updates on health policy that's really, really cool. And then sessions on how to build community and how to build power and stuff. Then on Sunday, there's going to be just an awesome health policy panel, including Public Citizen and other folks. And Sunday afternoon, it's going to be about how to advocate, how to lobby, how to do the work that we're going to be doing on Monday. Because on Monday, since we're in DC, we're going to be having a rally on Capitol Hill. And we're going to be, there's, I think, almost 200 people that have signed up to, there's more than that have signed up to go to the annual meeting, but there's almost 200 that have signed up to stay over on Monday so that they can have one-on-one lobby meetings with their elected officials, and we're helping to coordinate that. So that's why Sunday afternoon we're doing training on that, and it's we've never done this before. We've never done this before, so it's pretty exciting. November 1st through 3rd, and you should join us there. And let me wake up my speaker again. Yes, good. And yeah, I think I've stopped sharing. Yeah, yeah, I have. Good. Okay. What's on your minds?
Thank you so much, Dr. Weisbart. Uh, Incredible talk. It covered so many different topics. And uh, yeah, I look forward to just hearing about how the annual meeting goes because it seems like the national group is doing some new things and really just looking forward to see how that goes.
Well, you should look forward to seeing it in person.
I know. Residency interviews for me, but everybody else on the call, I can't speak.
I think we have a final exam for this block on November 3rd. I was otherwise considering it pretty strongly. But I am also um this leaves me very curious about how Badger Care works in Wisconsin and like if we have the information um concerning I don't know what we can do within our state system and if not, potentially how we can collect that information.
Is Badger Care the name of your Medicaid program in Wisconsin?
Yes.
Okay.
Sorry. Yes.
So yeah, our report, which is on our website and the report section, goes through what it means to deprivatize the Medicaid program in a state. It goes through states that have done it, what the process was that they followed, what the clinical results were. Spoiler alert, better, not worse, better. And I'll tell you the numbers for Wisconsin. Wisconsin specifically would save anywhere from 113 million to 193 million per year. So let's say 150 something, 113 to 193 million dollars per year if you did this or when you do this. So that's kind of an irresistible value proposition, don't you think? You can go to your state legislators and not say, "Don't cut this, don't cut that." You don't have to do that. Oh, please, it's not that. You go there with a bucket of cash. Here's $150 million a year you can save, and we are physicians and medical students. We're here to tell you you can save $150 million a year and improve the health of people in your community. So the report has links to model legislation. The report has a link to the one in Minnesota. They've got a bill there that they've been looking at. There will soon be a link on the website to model legislation from Hawaii. They're also doing it, and there's a bunch of other information. There's even beyond that. There's guidelines for what legislation in a state should look like, pitfalls to watch for, and if you want to do a bill for it, how to do it. So we spent like 6 months creating this. It's a hell of a resource.
Thank you so much. I'm also curious about because it seems unfortunately like in the current zeitgeist, the it is popular to immensely like slash Medicaid as it currently exists. It seems like that's why we have like the government shutdown currently. What does it look like on the ground when you're speaking with legislators? Is there because I know in general that policy like this is popular, and then you get to like political feasibility when things get polarized, and it's like a crazy situation. So many people saying, "Oh, like illegals are taking our Medicare, blah 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 blah, etc." So I'm wondering what actually having those conversations can look like.
I like the way my wife says that. Those lazy immigrants are stealing our jobs. So the report is now, I think, 3 weeks old. So I've only had conversations with some of the Democratic folks in Missouri. So I've had those conversations, and in Missouri we have a trifecta, or we have we have a veto-proof majority for the Republican Party, and so it's different conversations. I've not had those yet. We are just starting to explore those. I was doing that earlier today. But the Democrats that I've talked to are like, "Oh my God, this is great. This is something positive and constructive we can fight for." And what we're hoping, it's 3 weeks old. What we're hoping is that we can arm the Democrats to have an alternative when they get into their appropriations committee meetings and they get into their budget committee meetings and they're having to confront people making these horribly egregious proposals, which we outline in the report. Here's things you're probably dealing with in your state that you don't want to have to do. Here's the alternative. So we're hoping that the Democrats will be armed with how to represent this, and we're hoping that the Republicans will look at that and go, well, shoot, I don't want to waste this kind of money. I didn't know we were wasting that much money. I didn't know that Centene and the others were getting that much money that we can avoid. And you're saying you've got states that have done this. And so Connecticut did this in 2012. And since 2012, Connecticut says that they have saved $4 billion. and they're a small state. And they are Connecticut has been described as the world headquarters of insurance. Connecticut is described as the world capital of insurance. The world capital of insurance. So political barriers, you betcha they had them, but they found a way past them. Um, so um, so I'm hopeful that we can overcome that. I think because the message that we're giving, here's hundreds of millions of dollars you can save quickly, and they're dealing with budgets that are running into a and if you add that up, so if we added it up, right? So there's $43 billion that the federal government would start paying. There's another $34 billion that the states would stop paying. So it adds up to $77 billion a year that we would stop spending. And I'm not enough an economist to know how to model that to 10 years, but 77 billion times 10 is $770 billion. And how much did the budget reconciliation cut from Medicaid? A trillion. So we're talking 770 billion versus we're on the ball. We're on the page, man. We've got enough money here that the country can save that should get people's attention. So, and it's all spelled out in the report. The numbers are detailed breakdown how we came up with them. So yeah, very hopeful, but it's too new to give a real answer to your question.
That makes sense. Thank you so much. And I didn't realize that the report had like such a useful guide for working on the state level. I'm an M1. I just got here. I think a couple weeks ago spoke with Lori Clark, who I think is an organizer on like
Yeah.
yeah, and she attached us to an email chain with I think like the UF chapter in UMich. She was encouraging us to coordinate on some kind of legislative action in the state, and I think just getting any kind of bearings initially, because I think we could have sufficient interest to potentially try doing something here in Wisconsin. We just need to know where to start.
Don't sell yourself short, man. Students are like, you know, that I go to legislators and they're always looking at me like, yeah, you want to make some money. You're in practice, you want to do, students go and they look at you like you're these golden-haired, glowing, they love students and they trust you because they don't think you're as conflicted yet. They see that you're not jaded, and so you have a meaningful voice. And it's so easy, call up the legislator, especially now when I presume you're still off cycle right now and your legislators are not in session and they're home. Call them up and say, hey, I live in your district and I want to just talk to you. I'm a med student. Say you're a med student. That's okay to say. I'm a med student. I live in your district and I've got this thing I want to talk with you about Medicaid that I think you might find interesting, and give them the punchline. I think there's a way to save hundreds of millions of dollars for the state of Wisconsin, and I want to help you understand it. So call them up and say, and you don't know, they'll bite. So they're going to bite.
Great. Thank you so much. That's really encouraging.
Yeah. Okay.
Thank you, Dr. Weisbart. I was gonna say too, I think I feel inspired first that Emily's gonna take over the reins and I'll help her into that position. But I had an idea when I first took over the MCW SNaHP chapter to have like a journal club every once in a while or something that's a little more current and we can discuss and maybe come up with some better ideas. I think that an excellent journal club would be to just go over some of the main points of the reports that PNHP has put out, and talk about
Idea.
really actionable ideas that we can latch onto and put what little time we have outside of school like into directly. So I think that'd be really, really great, and I appreciate you sharing them.
They're all about our website now. We've fixed the website, so it's really easy to find them. So, great. I love that idea. Actually, I've not heard anybody say that before, but let's have a journal club that looks at the reports. I think that's brilliant. So
I'm going to say that in the old days, speaking from the Wisconsin, I've been in the Wisconsin chapter for 10 years. And in the very beginning, we actually used to have journal clubs. And we would have like a meeting with our steering committee, and then we would have like an educational the following month. So once every other month we would have, and we used to bring in articles and discuss, and we've fallen away from that and we're regrouping. But I think that's a fantastic idea. And maybe we can plan that for our next meeting. So that's a great idea, Sam. I think that's and this would be a great report because I had heard that it came out, but I have not looked at it yet. but it seems extremely powerful. And I think we need to understand it and share it. So that's great.
Cool beans. God, you guys, what a great way to have the end of a very long day that I've had. So it's just, that's awesome.
Yeah, thank you so much for sharing, and look forward to having you back next week. Hopefully we can rally the troops and get a few more faces on Zoom.
Yes, we're going to have